Hello students, I welcome you all to Obstetrics and Gynecology with Mackler. So in this module, we are going to deal about the WHO screening guidelines for cancer cervix. So we all know that cancer cervix is the fourth most common cancer to occur in females. So for that reason, we are going to start screening for cancer cervix in every single woman, irrespective of whether she is HIV positive or negative. Okay, so with us we have two guidelines for screening for cancer cervix. One is the American College of Obstetrician and Gynecologists guidelines, and the other is the World Health Organization guidelines. So in this module, we'll be discussing about the WHO guidelines for cancer cervix, which is very important, right? Okay. So WHO says that in order to start the screening for cancer cervix in female, what is the appropriate age? So the appropriate age to start screening in a female who is belonging to a general population is around 30 years, right? Start the screening for cancer cervix around 30 years. But when you ask when to start the screening in HIV positive females, we all know that HIV positive females, since they are immunocompromised and the HPV changes which happens in the squamous cells, it is said to be occur in a more prolonged fashion, right? In a hastened fashion. So they are even more susceptible to develop cervical cancer than the general population. So for that reason, we are going to start the screening in HIV positive patients even more earlier than in the general population. So you need to start the screening by around 25 years. Is that clear? Okay. So now, as per the ACOG guidelines, that is the American College of Obstetrician and Gynecologists guidelines, when is the appropriate age to start the screening in any female? It is 21 years, right? 21 years. So the WHO guidelines to start screening for cancer cervix in the general population is 30 years, and in HIV positive patients it is around 25 years. Remember, it is 30 and 25. So the ideal range to start the screening is around 30 years, right, in general population female. But when are you going to stop the screening in such females? You have to stop the screening by around 50 years, right, around 50 years. So the age group that WHO has covered in screening for cancer cervix is around 30 to 50 years. Why it is stopped by 50 years is because cancer cervix most commonly occurs by 50 years of age, and all the screening procedures are done before that age. So since cancer cervix occurs more commonly around 50 years of age, you need to screen the patient until 50 years. After 50 years, are you going to stop the screening abruptly, or is there any indication specific for this? Yes, there are certain indications. So what are the prerequisites? That by 50 years of age, while screening that patient, there has to be 2 consecutive negative reports. 2 consecutive negative reports. So you start the screening by 30 years in the general population female. You are going to screen that female until 50 years. You are going to screen. And how are you going to stop by 50 years? At 50 years, you are going to take screening in that patient, and if 2 consecutive screening samples turn out to be negative, then you can stop the screening for cancer cervix in that female by around 50 years. Is that clear? General population 30 years, HIV positive patients 25 years, stop the screening by 50 years. What is the indication to stop the screening? 2 consecutive negative sampling. Is that clear? Okay. So this is all about the WHO guidelines now. So what is the actual screening test which is recommended by the WHO? So WHO has 2 approaches. WHO has 2 approaches. Please concentrate over this, because this is even more important when it comes to your MCQ examination, right? WHO gave us 2 approaches. One is see and treat approach, right? One is see and treat approach, and the other is see, triage and treat approach. See and treat approach and see, triage and treat approach. So in this module, we will be discussing everything about the see and treat approach. That is, we will be discussing about the one. The second part, that is the see, triage and the treat approach, will be discussed in the next module. Is that clear? Okay. So what do you mean by the see and treat approach? So C stands for screening and treat stands for treatment. So basically you are going to do a single screening test, and based on the reports of that single screening test you are going to follow up with the treatment. Let's say for example, if the screening test is HPV DNA testing. HPV DNA is the most common cause or most common risk factor for cancer cervix, right? The high risk subtypes are the HPV 16 and the HPV 18. So HPV DNA testing as a screening test, if the reports comes to be positive, then you have to follow up with the treatment. So the decision to do the treatment is decided upon the single primary screening test. So C and treat approach is nothing but C stands for a single screening test, and based on the reports of that single screening test you are going to perform the treatment. So one screening test, what is the report? If it is positive, do the treatment. If it is negative, repeat the screening after said years. Is that clear? Okay, so now let's discuss about the see and treat approach. So WHO recommends two approaches. One is see-treat approach, another is the see-triage and the treat approach. As see-treat approach is concerned, WHO tells that either you can do HPV DNA testing or visual inspection with acetic acid. Right? We have discussed about all these testings in the previous module. VIA stands for visual inspection with acetic acid. So what do you mean by visual inspection with acetic acid? That you're going to take around 3 to 5% of the acetic acid and apply it over the cervix, and visually you're going to inspect for any aceto-white areas being present in that cervix. If aceto-white areas are present in the cervix, it indicates that abnormal tissues are present in that part of the cervix, right? So either you have to do HPV DNA testing or VIA, that is visual inspection with acetic acid, as the primary screening test in see and treat approach, right? Okay. Now, let's say for example that you have done either the HPV DNA testing or the visual inspection with acetic acid. If the report comes out to be positive, you have to go up with the treatment. And once the treatment is done, you have to ask the patient to be in the follow-up, right? So first, the report can come as positive or negative. If the report comes to be positive, you have to consider treatment, because in see and treat approach, the decision to treat is based on the report of one single screening test. And if the report of the single screening test comes out to be positive, you have to take the treatment decision. And once the treatment is done in that female, you have to ask the patient to be in the follow-up after 6 months or so. Is that clear? Okay. But if it comes out to be negative, what are you going to do? Any test, please remember, if it is going to be negative, you need to repeat it after a few years. So in that case, you're going to repeat the HPV DNA screening in general population by 5 to 10 years. After 5 to 10 years, you have to repeat the screening. But in HIV positive females, since they are more susceptible, you have to repeat the screening by around 3 to 5 years. Is that clear? Yes, in general population, you repeat after 5 to 10 years. In HIV positive females, you repeat it after 3 to 5 years. This is for HPV DNA. VIA is concerned, you have to repeat it after 3 years, right? So I told in see and treat approach, we have a primary screening test, and that primary screening test can be either HPV DNA testing or the visual inspection with acetic acid. If the HPV DNA testing comes out to be positive, you have to take the decision of treatment based on the positive report. And once the treatment is done, you have to follow up the patient after 6 months or so with HPV DNA testing. Okay? Yes. And if you have taken visual inspection with acetic acid as the primary screening test, the decision to make the treatment is dependent on this primary screening test. And once the treatment is done, you have to ask the patient to be in the follow-up after 6 months. And in that case also, you're going to check with HPV DNA testing. So the follow-up is always with the HPV DNA testing. Is that clear? Follow-up is always with the HPV DNA testing. Right? This is all about the positive side. But when you do the screening test, if the reports of the screening test turns out to be negative, you have to repeat the test, when are you going to repeat the test? If you have taken HPV DNA testing as the primary screening test, you have to repeat the HPV DNA test after 5 to 10 years in general population females and after 3 to 5 years in HIV positive females. But in case if you have taken visual inspection with acetic acid, that is VIA as the primary screening test in see and treat approach, you have to repeat the VIA after 3 years in both the general population females as well as in the HIV positive females. Is that clear? Yes. So you can take either HPV DNA as the primary screening test or the VIA. Yes? Okay. So now I have the WHO guidelines. This picture has been taken off from the WHO guidelines website. Okay. So what are the algorithms which are being given? We are going to discuss it now. Okay, so here what it is given here is primary VIA screening, screen and treat approach. So in screen and treat approach, they have taken VIA as the primary screening test. So what is the VIA? Visual inspection with acetic acid. You're going to take 3 to 5% of the acetic acid and apply it over the cervix, and visually you're going to inspect the cervix. If you're going to see some aceto white areas, that indicates the abnormal parts of the cervix, right? Okay, so if the VIA testing comes out to be positive, what are you going to do? If it comes out to be negative, what are you going to do? If it turns out to be positive, you need to consider the treatment options because the primary screening test, that is the VIA, turns out to be positive. So the decision to treat is based on the VIA. So now we all know that the treatment is going to be either the cryoablation or the excisional procedure such as the LLETZ or LEAP, right? Yes. So if the report turns out to be positive when you have done the VIA, you have to check whether the patient fits under the guidelines or the indications are properly fit for ablation. If the patient is eligible for the ablation, go for the ablative treatment, that is a cryoablative treatment. But in case if the patient is not eligible for ablation, go for the excisional procedures. We have discussed all these in the previous module, and the excisional procedure that we know is large loop excision of the transformation zone. Yes, clear? Yes. So if you are going to do some excisional procedure, you will be left out with some tissues, and this tissue will be subjected to histopathological examination. In the histopathological examination, if it comes to be cervical intraepithelial neoplasia, anything less than type 3, less than type CIN3 or or the adenocarcinoma in situ, CIN1, CIN2 or adenocarcinoma in situ, now you have to put the patient in just follow up after 1 year, right? But if it is going to be a cancer, you have to follow up it with biopsy, right? In any case of suspected cancer, or if the reports which you have subjected to histopathological examination is reporting as a cancer, you have to follow up it with the biopsy, and based on the biopsy, you have to further evaluate and do the management. Is that clear? Right? So I have told in see and treat approach, the primary screening test in this guidelines they have given us VIA. So VIA is positive. Now you can do 2 treatments. If the indications for cryoablation are met, do cryoablation. If the indications are not met, you have to do some excisional procedure, that is the LEAP or LLETZ. Excisional procedure will be left out with some tissues, right? If you are going to do some excisional procedure, you will get out some tissue sample. You are going to subject this tissue sample to histopathological examination. In histopathological examination, the report comes out to be either CIN1, 2, 3 or adenocarcinoma in situ. If it is CIN1, 2 and adenocarcinoma in situ, it is not an invasive cancer. Since it is not an invasive type, you have done the treatment already. So you can confirm the diagnosis and put the patient only on follow-up after 1 year. But when you do the histopathological examination, it comes out to be some cancer. So since it is a cancer, you have to follow up it with any biopsy, and the further management will be taken off. Okay, so this is all about the positive side. In any case of suspected cancer, you have to do biopsy and the further management will be decided. If it is negative, what I have told you, if VIA is negative, you have to repeat it after 3 years in both general population as well as in the HIV positive females. So that is 3 years. Right? So this guidelines has been given both for the HIV as well as in the general population female. Right? So we have completed algorithm 1, Now we are going to the last algorithm of this module, that is algorithm 2. So here they have taken HPV DNA test as the primary screening test. Right? So HPV DNA test has been done, and if it comes out to be positive, what are you going to do? If it comes out to be positive, the decision to make the treatment is dependent upon the primary screening test. So since the primary screening test is positive, you have to consider treatment. So now you check for whether the patient is coming under the indications or the patient is fulfilling the indications for cryoablation, which we have discussed in the previous module. If she is fulfilling the indications for cryoablation, you go for ablative treatment. If she is not eligible for ablation, you have to go with some excisional procedure such as LEEP or LLETZ. And similarly, you subject it for histopathological examination. Anything which is less than the cervical intraepithelial neoplasia type 3 or the adenocarcinoma in situ, you can do just the follow-up. Since you have confirmed the diagnosis that it is not a cancer and it is not an invasive cancer also, you can keep the patient in just follow-up after 1 year. But it turns out to be cancer, you have to evaluate it with biopsy and the further management will be decided. Similarly, in case of suspected cancer, do the biopsy and the further management will be decided further on. Right? Yes. So if it comes out to be negative, if the HPV DNA test comes out to be negative, I told that in general population, you have to repeat it after 5 to 10 years. In HIV positive females, you have to repeat it after 3 to 5 years. Is that clear? Yes. So now let me give a short gist that what are the indications for cryoablation. No invasive cancer should be present. No adenocarcinoma in situ or adenocarcinoma should be present. No endocervical involvement, and any lesion which is present in the transformation zone, it shouldn't extend inside the endocervix. Right? These are the particular indications for cryoablation. If all these indications are met, you go for cryoablation. Not met, go for excisional procedures such as the large loop excision of the transformation zone or loop electrosurgical excisional procedure. Right? So this was all about the see and treat approach. So C was all about the primary screening test. And here we had the primary screening test as either the HPV DNA or the VIA. So based on the report of this primary screening test only, the treatment decision is taken. Right? You repeat HPV after 5 to 10 years in general population, 3 to 5 years in HIV positive females, VIA 3 years in both general population as well as in the HIV positive females. So this was all about the see and treat approach. Now, when we discuss the see, triage and treat approach in the next module, one thing is that in see and treat approach, you do the primary screening test and you do the treatment based on the report of the primary screening test. But in see, triage and the treat approach, you do the primary screening test. Right? You do the primary screening test, followed by that, if it comes out to be positive, followed by the primary screening test, you are going to do this triage test. You're going to do the triage test, and based on those, you're going to decide upon the treatment. So between the primary screening test and the treatment, there is a test that is a triage test. So about the see, triage and the treat approach, we'll be discussing the next module. The see, triage and the treat approach is highly recommended by the WHO than the see and treat approach. So they tell that see, triage and treat approach is much effective than the see and treat approach. So indirectly, see, triage and treat approach is more important than see and treat approach, which we'll be discussing in the subsequent next module. Is that clear? I hope that I made this topic to be very simple for you. In case if you have any doubt, as usual, whatever I tell you, you can write to us in the Mackler handle. I hope I'm reaching out to you as early being possible. Right? So let's meet in the next module.